and lowest in North America. In a recent global study assessing the prevalence of different types of infection amongst patients with cirrhosis and ascites, spontaneous bacterial peritonitis turned out to be the most common infection, occurring in approximately 27% of these patients, surpassing urinary tract infection and pneumonia. So spontaneous bacterial peritonitis is the infection of the acidic fluid in the absence of any intra-abdominal or surgically treatable source. There are various types of bacterial peritonitis. Spontaneous bacterial peritonitis is defined by a positive acidic fluid culture together with an elevated polymorphonuclear count of more than 250 cells per milliliter. However, as we all know, that the acidic fluid culture may not always be positive, and these cases are called culture negative neutrocytic ascites if the PMN count is elevated. However, in some situations, the acidic fluid culture is positive, and yet the PMN count is low, less than 250 cells per mil, and these cases are known as monomicrobial non-neutrocytic bacterial ascites. The first two cases are likely to represent the same type of infection, and they both have a negative impact on the prognosis of these patients. However, monomicrobial non-neutrocytic bacterial ascites is likely related to contamination of the acidic fluid culture. Now, how does a patient with SBP present? The patient may present with typical symptoms of infection such as fever, chills, or hypothermia. The patient may complain of abdominal pain, together with a rapid increase of abdominal distension, or the patient may complain of malaise and fatigue. However, quite often patients are asymptomatic, and therefore the treating physician will need to have a very high degree of suspicion, especially if the patient has suddenly deteriorated in his clinical state, such as the development of hepatic encephalopathy or acute kidney injury. Now, before we talk about management of spontaneous bacterial peritonitis, we need to understand a little more about the pathogenesis of SBP. On the left-hand side, you see a patient with a healthy liver, no cirrhosis, and of course, these are the resident bacteria, and the patient has a very intact epithelium together with a thick layer of mucus, and the thick layer of mucus together with the intact epithelium form a mucosal barrier to prevent these bacteria from entering into the submucosal space. And here is our patient with liver cirrhosis and ascites. And of course, things are very different. First of all, there is an overgrowth of different types of bacteria. Some may be pathogenic, and you have a thinning of the mucosal mucus layer together with changes in the underlying epithelial layer. And so we will go through all of these changes one by one. First of all, there is bacterial overgrowth. This is related to the fact that the state of cirrhosis is associated with decreased bile acid production. Cirrhosis is an inflammatory state, and there is inflammation-dependent inhibition of CYP7A1, which is the enzyme responsible for regulating the metabolism of cholesterol into production of bile acids. There is a relative greater reduction of secondary bile acids which will favor the overgrowth of pathogenic bacteria. The bile acids themselves usually will also have a mucosal protective effect, and when you have reduced amount of bile acids, the protective effects are also compromised. In addition, cirrhotic patients have got slow transit time in the gut. This is especially evident in the small bowel, where at least 35% of patients will show delay in small bowel transit. Of course, that also occurs in the stomach and also in the colon. And the overall slow transit of the bacteria will encourage further bacterial overgrowth initiated by decreased bile acid production. And of course, there are changes in the microbiota in cirrhotic patients with significant increases in potentially pathogenic organisms such as Staphylococci, Enterococci, Enterobacteriaceae, and also significant decreases in autochthonous taxa such as Clostridiales, Ruminococcaceae, and Leptospiraceae. The microbiome changes the microbiome will also undergo further changes when you have further infections, organ failures, or the development of acute or chronic liver failure. So, the thinning of the mucus layer, as I mentioned before, the mucus layer is the first layer of protection against the bacteria from gaining access into the submucosal layer. And this experiment elegantly demonstrates that there is thinning of the mucus layer in relation to increased inflammation, increased amount of bacterial products, and also the presence of various cytokines. You can see in this micrograph that there is thinning of the mucus layer compared to control subjects, and quantitatively you can also see that the thickness of the mucus layer is significantly reduced compared to healthy controls. And of course, underneath the mucus layer, the epithelial cells themselves are also being damaged as a result of portal hypertension that exists in cirrhosis. Portal hypertension leads to mucosal congestion, and that can lead to relative hypoxia of the mucosal surface, leading to oxidative stress and ultimately epithelial apoptosis. And as the epithelial cells die, you can actually get a loosening of the tight junctions, contributing to the leaky gut syndrome, thereby allowing microbial products to gain access into the submucosal space. This is a very elegant study showing you that various compounds that are present at the tight junction, such as cadherin and occlusion, they are quantitatively reduced when you incubate an organism such as E. coli together with the epithelial cells. And the longer you incubate the bacteria with the mucosal cell, the more the reduction in the amount of these tight junction molecules. And the lower panel shows that when you incubate for a fixed amount of time, the more organisms you incubate with the epithelium, the more you're likely to get reduction in the amount of these tight junction molecules. So to summarize it up here, you can see that's our mucus layer that's being thinned out. Here you have small intestinal bacterial overgrowth, more bacteria together with bacterial products such as lipopolysaccharide, together with the apoptosis of the very epithelial cells. You can actually get leakage of all of these products into the submucosal space, leading to activation of the submucosal white cells, and together endotoxins, bacterial products, bacterial and necrotic cell products and cytokines all get transferred through the portal vein into the liver. And of course, when the patient, when all these products get to the liver itself, you would usually is an immune organ. The immune function is compromised. Some of the bacteria and bacterial products are being shunted directly to the systemic circulation through pre-existing portal systemic shunt. In addition, the formation of a basement membrane called sinusoidal capillarization compromises the receptor function of the sinusoidal cells, and therefore the white cells that are in the subendothelial space are unable to reach the various bacteria and bacterial products to neutralize them. In addition, cirrhosis is associated with reduction in protein synthesis, and therefore all of these auxiliary compounds that are required for intact immune function are being compromised, giving you an overall immunodeficiency state of the cirrhotic patients. And therefore, the end result is one of many of these bacterial products and bacteria reaching the systemic circulation, and from there to seat the acidic fluid. And of course, there are other risk factors for SBP development in patients with cirrhosis. Patients who have got advanced stage of liver disease, they are usually associated with more marked immune dysfunction, and also patients who have had a previous episode of SBP, or patients who have GI bleeding or low acidic fluid protein count. They are the candidates who are more likely to develop bacterial peritonitis. So how do I deal with a patient whom I think may have SBP? So first of all, the patient either has features to suggest the presence of SBP, or I have a very high degree of suspicion. Then I'll need to do a diagnostic paracentesis, taking out sufficient acidic fluid to ask for acidic fluid cell count together with a differential count to determine whether the polymorphonuclear count is more than 250 per mil. There's also, I also need to send the acidic fluid inoculated at the bedside, 10 mils into an aerobic and 10 mils into an anaerobic blood culture bottle. And usually a couple of hours later, the PMN count is back. If it is lower than 250 cells per mil, and if the patient continues to have symptoms and signs to suggest an infection, then I should start empirical antibiotic therapy and wait for the culture. If the culture is negative, then the antibiotic is not indicated. However, if the culture is positive and the cell count is less than 250, and then the patient is likely to have bacterial ascites, and I should repeat the diagnostic paracentesis. In contrast, if the cell count comes back as being positive and indicative of bacterial peritonitis, I should make the presumptive diagnosis and begin empirical antibiotic therapy, a third-generation cephalosporin together with intravenous albumin, especially if the patient has got high risk of developing kidney failure, and these are the patients with a high baseline serum creatinine or a total bilirubin of more than 4 milligrams per deciliter. You've started the antibiotic, you wait for the culture results. If the culture results are negative, you complete the 5-day course of antibiotic treatment. If the culture is positive, then at least you've got this sensitivity to allow you to narrow the antibiotic regimen if necessary. And you also complete the 5-day course of treatment. Now, the organisms involved in SBP are still mostly gram-negative bacteria, such as E. coli, Klebsiella, or Pseudomonas. However, in recent years, we've seen an upsurge of gram-positive bacteria being responsible for the development of SBP, and these include Enterococcus, Staphylococcus coagulase negative organisms, Strep viridans, Staphylococcus species, and other Strep species. And more recently, we need to worry about multi-drug resistant bacteria being responsible for approximately a quarter of the cases of SBP. And so, do we need to adjust the antibiotic treatment? The answer is yes. If you think that the SBP is community acquired, that is, the patient has not had any contacts with hospital in the last 6 months, you usually start off with a third generation cephalosporin because the patient is most likely to have a gram-negative organism being responsible for the SBP. If the patient has developed the SBP after having been in hospital for 48 hours, then you need to broaden the antibiotic cover using piperacillin, tazobactam, and together with daptomycin if the patient is known to have vancomycin-resistant enterococcus in the past, or the patient has evidence of GI colonization with VRE, or if the patient is known to have harbored multi-drug resistant gram-negative organisms, then you need to add meropenem. If the patient has had contact with hospital in the last 6 months, then you also need to use broad-spectrum antibiotics such as piperacillin, tazobactam, or cefepime, which is a fourth-generation cephalosporin, which is very broad gram-positive and gram-negative coverage, or levofloxacin or vancomycin if the patient is known to have a positive MRSA culture or screening or prior antibiotics in the last 90 days. Now, as I mentioned before, multi-drug resistant organisms are now on the rise, and the prevalence are different in different parts of the world, depending on how tight is the antibiotic stewardship in that particular region, being highest in subcontinent in Southeast Asia, in the subcontinent of India, being lowest in North America. And this is just to show you that in the different parts of the world, the Asian country, India, has the most prevalence of multi-drug resistant organisms, as well as the most extensively drug-resistant organisms in the world. And therefore, it is incumbent upon us to really be careful with our antibiotic use so that we don't create all these multi-drug resistant and extensively drug-resistant organisms. Now, I mentioned previously that we need to use albumin in the treatment of patients with SBP. Albumin is being used not only because of its oncotic properties, and of course, in patients with SBP, not only do they have an infection, they may also have worsening of the hemodynamic changes with more vasodilatation, and therefore albumin is good to fill up the intravascular volume. However, albumin is also useful because it has endothelial stabilizing effects. It also can improve the immune function of these patients. In addition, albumin can counteract the oxidative stress and the cytokine storm that are seen in patients with SBP. And therefore, albumin is recommended to be given on day 1 and day 3 at a dose of 1.5 per kilogram of body weight on day 1, 1 gram per kilogram of body weight on day 3. And although this study is rather old, but it showed us that in patients who received ceftriaxone together with albumin, there was a significant reduction in the incidence of renal failure, mortality within the hospital, and the benefits appear to extend beyond the hospital admission because the mortality in the 3 months after discharge was also significantly reduced. And so the American Association for the Study of the Liver suggests that after you have initiated antibiotic treatment, you need to do a diagnostic paracentesis within 48 hours to look for a reduction in the acidic fluid PMN count by 25%. If that is the case, then you know that the patient is receiving appropriate antibiotic treatment and it's responding nicely, and therefore you just complete the 5 days of antibiotic treatment. If the PMN count is not decreasing, then you're likely not giving the patient appropriate antibiotic treatment, or there may be a secondary cause for the bacterial peritonitis, or the patient is developing organ failure. And at that stage, depending on whether the patient is a liver transplant candidate, then you either transfer the patient into intensive care, or you need to initiate discussions with the family about palliative care. And in this worldwide study on infection, you can see that spontaneous bacterial peritonitis is a risk factor for the development of acute on chronic liver failure, a syndrome that is associated with multi-organ failure. And you can see that in this study, at least 58% of patients with infection develop acute on chronic liver failure, some occurring at the time of infection, others occurring after the infection was started. And the reason why patients with bacterial peritonitis can develop acute on chronic liver failure is because all these bacteria and bacterial products can initiate an inflammatory cascade with production of many inflammatory cytokines, as well as vasoactive compounds such as nitric oxide. The inflammatory cytokines can activate various white cells to release cytokines, further proteases, and these will induce cell necrosis, induce oxidative stress, and all of these can lead to organ failure. And as you can see in this study, spontaneous bacterial peritonitis is a risk factor for the development of ACLF. And of course, all of these patients also have ascites. And then if you add on the fact that the patient has got a high baseline MEL score, who developed the infection after 40 hours in hospital, or if the patient develops encephalopathy, then the patient is likely to develop acute on chronic liver failure during the episode of SBP. And here is a study from the North American Consortium for the Study of Liver Disease, showing you that in patients who develop acute on chronic liver failure with an infection, survival is significantly reduced compared to patients who developed acute on chronic liver failure without an infection. In fact, this European study shows that for every grade of acute on chronic liver failure, the presence of a bacterial infection significantly worsens the patient's survival. However, in patients with grade 3 acute on chronic liver failure, or patients who have had more than 3 organ failure, they're so sick it really doesn't matter whether the patient has got bacterial infection or not. The patient is not likely to survive. And so after the patient has recovered from an episode of SBP, the recurrence rate is 70% at 1 year. Since we have not worked out which patients are at higher risk for developing recurrence, we are now recommending universal secondary prophylaxis. And the recommended antibiotic is norfloxacin, 400 milligrams daily until liver transplant or death, Alternatively, you can use ciprofloxacin 500 milligrams daily. Other antibiotics that have been studied include Septra double strength 1 tablet twice daily, or rifaximin 550 milligrams twice daily. What about primary prophylaxis? That is giving patients antibiotics before the first episode of SBP. This is a North American consortium study showing that in patients who receive primary prophylaxis, there is actually more cases of acute kidney injury in inpatients, and also significantly higher in-hospital mortality. And therefore, universal primary prophylaxis against SBP is not recommended. And however, in patients with advanced stage of liver cirrhosis, such as those with a Child-Pugh score more than 9, a bilirubin of more than 3 milligrams per deciliter, together with some hemodynamic changes as suggested by a high baseline serum creatinine or the presence of hyponatremia. Patients who have got a GI bleed should receive primary prophylaxis for 5 to 7 days. And of course, patients with low acidic fluid protein count of more than 1.5 grams per deciliter should also receive primary prophylaxis. And so a first episode of SBP confers a negative impact on the patient's prognosis, as indicated by this study from my institution, showing that over the course of 1 year, patients who have had an episode of SBP have significantly reduced survival. In addition, they also have got a higher likelihood of developing an episode of AKI, an episode of SBP, and higher likelihood of developing hyponatremia. And as a result of all of these complications, they're more likely to require liver transplant. The same information is borne out in 2 other studies. This is a Danish study showing that patients who have had an episode of SBP, they have got significantly worse prognosis over the course of 12 years, with most of the deaths occurring earlier on after the episode of SBP. And in this particular study, which assessed the outcome of patients who received ceftazidime in its multinational, multi-center study, showing once again that the patient who have had an episode of SBP had a significantly higher mortality rate compared to patients who never had an episode of SBP. And so to summarize, patients with cirrhosis and ascites have a high risk of developing spontaneous bacterial peritonitis. The early administration of effective antibiotic treatment is crucial. SBP can trigger the development of ACLF with worsening of the prognosis. Even after recovery of the index episode of SBP, patients are at risk for further decompensating events with worse prognosis. Primary prophylaxis is only recommended for selected patients, as universal primary prophylaxis can lead to worse outcomes. Secondary prophylaxis, however, is mandatory in order to prevent recurrence of SBP. I will stop here and thank you for your attention.
Thank you, Professor Wong, for that excellent talk. And we'll have the questions in the end in the discussion. So I would like to call my co-moderator, Professor Diana is here to introduce the next speaker, Professor Paolo Angeles.
Good evening, everyone. Singapore Airlines flight.
Professor Diana.
So good evening to everyone. I would like to introduce our next speaker to talk on acute liver failure and renal failure on patients with ACLF as well as SBP is Professor Paolo Angeli. I think he has given his video. So Izumi, can you load the video in? Thank you.
Dear Diana, dear Aki, good afternoon or good evening. Let me thank the organizer of this webinar for this kind invitation. I'm really happy to be with you today. So I will start my talk with a clinical case, a very simple clinical case. I'm speaking about a 54-year-old woman admitted to our unit in January 2022 for a severe impairment of her cognitive status. Her relatives reported that she had had diarrhea in the 3 days before. In the emergency department, a cerebral CT scan was negative for acute ischemic or hemorrhagic events. Two main diagnoses in her previous medical history. In 2015, diagnosis of infiltrating ductal carcinoma in the right breast that was treated with surgery and hormonal therapy. In 2018, diagnosis of decompensated liver cirrhosis due to PSC, and the previous decompensating events included grade 2 ascites well controlled by the standard of care, and 2 episodes of hepatic encephalopathy. The patient had large esophageal varices at upper endoscopy, but no evidence of ACC and or portal vein thrombosis at abdominal ultrasonography. This was her therapy on admission: diuretics, beta blocker, rifaximin, and ursodeoxycholic acid. On admission, the vital signs were normal, in detail, no fever. There were jaundice and signs of dehydration. The patient was awake but disoriented, with flapping tremor, but no side signs. The abdomen was painless, with moderate ascites and superficial collateral venous reticuli. These are the lab instrumental investigation on admission: normal white blood cell, a moderate anemia, a reduced platelet count, an high value serum bilirubin, an high INR, hypoalbuminemia, normal serum creatinine, moderate hyponatremia, moderate hypokalemia, no evidence of systemic inflammation. The workup for infection was negative: no SBP, no urinary tract infection, no pneumonia. So on admission, the serum ammonia level was quite high. Accordingly, the patient received enemas with lactulose together with intravenous saline solution and temporary withdrawal of diuretics, with a good initial response, with improvement of the neurological state and restore hydration condition. But on the 3rd day of hospitalization, the patient developed fever with chills, relapse of encephalopathy, and reduction of urinary output. At that time, there was arterial hypotension, normal heart rate, but the patient was still on beta blocker, an increase in respiratory rate. The white blood cell was still normal. There was a further increase in serum bilirubin. The INR was stable. There was still a moderate hyponatremia. The serum potassium level was normalized. There was evidence of systemic inflammation, and the serum ammonia level was still very high. But overall, there was a huge increase in serum creatinine. So we decided at that time not to insert a bladder catheter. So after the workup for infection, which highlighted a suspected urinary tract infection, we made the initial diagnosis of UTI-induced AKI initial stage 2 based on the increase in serum creatinine. You know that according to the KDIGO criteria, the diagnosis of AKI can be based either on the increase on serum creatinine or on the reduction of urinary output. Focusing on the increase in serum creatinine, you can make the diagnosis of AKI either in presence of an absolute increase in serum creatinine equal or higher than 0.3 milligram DL in less than 48 hours, and this was the case of our patient, or a percent increase in serum creatinine equal or higher than 50% in less than 7 days. You know, there is a staging system according to the increase in serum creatinine from baseline, less than 2-fold stage 1, in between 2 and 3-fold stage 2, and this was the case of our patient, higher than 3-fold stage 3. Well, now I want to highlight the relevance of the second parameter on which you can base the diagnosis of AKI, the reduction of urinary output below 0.5 ml per kilo body weight for more than 6 hours. Also, in this case, there is a staging system based on the length of oliguria or anuria. Well, if you have a patient with a bladder catheter and a flow meter, please use both the criteria, the increase in serum creatinine and the reduction of urinary output, because this may facilitate the diagnosis of AKI. In addition, this makes it possible to make a more adequate prognosis for your patient as compared to the use of only one criterion. But let me go back to our case because I want to highlight the relevance of the initial AKI stage for the management. I stated that our patient had an initial AKI stage 2 that is associated with a very high in-hospital mortality, not different from patient with initial AKI stage 3, but much higher than in patient without AKI, than in patient with AKI stage 1. And finally, patient with initial AKI stage 1 have a higher mortality than patient without AKI. So the prognostic impact of the initial AKI stage is so powerful that when we decided to accept the KDIGO criteria to make the diagnosis of AKI, we proposed a new algorithm for its management based on the initial AKI stage. So on your left, you have the initial AKI stage 1. On your right, initial AKI stage higher than 1. The first group of patients should be treated very, very promptly with a very simple measure. So withdrawal of nephrotoxic drug, withdrawal of beta blockers, withdrawal of diuretics, a deep workup for infection and treatment of infection when diagnosed. In case of response, everything is fine, but the patient should be closely followed because even transient AKI is associated with the reduction of survival. Why? For several reasons, but among them, one is the risk to develop other episodes of AKI that is related not only to the level of bilirubin, cystatin C, but also to prior episodes of AKI. In case of no response without progression of the AKI stage, any further decision on treatment should be based on case by case. In case of no response without progression of AKI stage, the patient moves to the right side of the algorithm and should receive the plasma volume expansion by high doses of albumin, 1 gram per kilo body weight for 2 consecutive days. That is the treatment that patients who have an initial AKI stage higher than 1 receive from the beginning. In case of response, everything is fine. In case of no response, the patient should be checked for all the criteria of hepatorenal syndrome. If the patient fulfills the criteria, he should be treated immediately by vasoconstrictor plus albumin. If the patient does not fulfill the criteria, it could be treated by other options when indicated. So going back to our clinical case, on the suspicion of urinary tract infection, the patient was treated with empirical antibiotic therapy with piptazole. Beta blocker was withdrawn, and the patient received the plasma volume expansion with high doses of albumins I mentioned before. You can see that there was no significant reduction of serum creatinine in the following 48 hours. There was no hematuria, no significant proteinuria. So we made the final diagnosis of UTI-induced HRS-AKI peak stage 2. Let me highlight that the differential diagnosis among the 4 phenotypes of AKI in patients with cirrhosis is not so simple. But let me say that pre-renal AKI is solved in most of the cases by plasma volume expansion. Post-renal AKI is rare. So the real problem is to differentiate in between ATN AKI and HRS AKI. And what we have our whole definition of hepatorenal syndrome, according to which hepatorenal syndrome is a functional renal failure. What does it mean? It means a renal failure without parenchymal damage. On this basis, we made the diagnosis of HRS-AKI in our patient according to the old criteria for the diagnosis of HRS, from which we deleted only the final value of serum creatinine. So nowadays, in a patient who does not respond to the withdrawal of diuretic and plasma volume expansion, we can make the diagnosis of HRS-AKI in case of absence of shock, no treatment with nephrotoxic drugs, no evidence of parenchymal damage as indicated by significant proteinuria, hematuria, and/or abnormal renal ultrasonography. The question is, are these criteria enough adequate to rule out the presence of parenchymal damage and particularly tubular damage? The answer is no, because if we look to a platform of new biomarkers of tubular damage, you can see that abnormal values are not only present in patients with ATN-AKI, but also in patients with HRS-AKI as compared to those with pre-renal AKI, and particularly to those without AKI. The higher number of new biomarkers with abnormal values, the lower probability you have to confirm your initial diagnosis of HRS-AKI, and the higher probability you have to end with a diagnosis of ATN-AKI. But this finding suggests the need to change our definition of HRS-AKI. HRS is probably predominantly functional in nature, but it may be associated with some degree of parenchymal damage in a continuum spectrum of kidney damage in between functional AKI and structural AKI. Putting HRS-AKI in the middle between pre-renal AKI and ATN-AKI. But overall, these findings raises some questions. The first one, are these new biomarkers useful to facilitate the differential diagnosis in between HRS-AKI and ATN-AKI? The answer is yes. This is true for urinary IL-18, but overall for urinary and gall, because there is no much overlap in values between patients with HRS-AKI and ATN-AKI. The second question, why there is parenchymal damage even in patients with HRS-AKI? Well, let me say that nobody at this time think anymore that the only driver of HRS-AKI is renal hypoperfusion. There are at least 3 other powerful drivers that are microvascular dysfunction, direct tubular damage, and overall inflammation and oxidative stress. Let me highlight inflammation and oxidative stress. When pumps and dumps arrive in the peritubular capillary, they will attract immunocells. Step 1, with production of pro-inflammatory cytokines and very dangerous agents such as nitric oxide and ROS. Step 2. Step 3, these agents will induce damage of the endothelial cell with microthrombosis. Step 4, these agents will invade the interstitial space, provoking the death of tubular epithelial cell with different modalities: apoptosis, pyroptosis, and necrosis. Let me say that within the tubular epithelial cell, there is also a reduction of the availability of antioxidant agents such as nicotinamide adenine dinucleotide, NAD, that is a powerful antioxidant agent. Why? Because the metabolism of tryptophan down the path of kynurenine is completely impaired. Particularly, the conversion of quinolinic acid into NAD is completely impaired because the enzyme which catalyzes this reaction, the quinolinic acid phosphoribosyl transferases, is completely blocked. So it is not surprising to observe an increase of the urinary level of quinolinic acid in patients with cirrhosis who will develop AKI. It is not surprising to see that there is an increasing value of quinolinic acid in the urine of patients who develop AKI during sepsis or in patients who develops AKI in acute on chronic liver failure. So let me summarize the histological findings that may occur even in patients with HRS-AKI. Excessive vasoconstriction, redistribution of blood flow toward the medulla, microthrombosis in peritubular capillaries, polymorphonuclear cell infiltration, and overall death of the tubular epithelial cell with different modalities. But let me go on with the most important question. Which is the impact of parenchymal damage on the efficacy of the pharmacological treatment of HRS-AKI? Before to address this question, let me highlight briefly the treatment that is based on the use of terlipressin plus albumin. Initially, terlipressin was proposed by intravenous boluses every 4-6 hours. But this is not the best way to use this drug. Why? Because by giving terlipressin by intravenous boluses, you cannot assure a continuous lowering effect on portal pressure, as you can do by using the drug by intravenous continuous infusion. So some years ago, we performed a small controlled clinical trial comparing the use of terlipressin by intravenous continuous infusion versus intravenous boluses in patients with HRS-AKI. You can see no significant difference in terms of recovery of renal function. But when you use terlipressin by continuous intravenous infusion, you can get the result using a much lower dose. And this makes it possible to reduce by half the rate of severe adverse effect, which means that you can treat and you can continue to treat a larger proportion of patients. And we are speaking about a treatment that is capable to improve survival in responders, that is capable in patients who will get a liver transplant to reduce the probability to develop CKD 1 year after liver transplantation. So let me go back to our patient. The patient was treated with terlipressin by intravenous continued infusion plus albumin. And she had a very, very good response with a normalization of the serum creatinine level. So I want to close the clinical case saying that the UTI was confirmed by the culture. The UTI was solved by the antibiotic treatment. There was no withdrawal of, there was no recurrence of HRS-AKI at the withdrawal of the treatment with terlipressin plus albumin, and the patient was discharged, reintroducing propranolol and low dose of diuretics. And now let me address the question. If there is some degree of parenchymal damage, even in patients with HRS-AKI, which is the impact on parenchymal damage on the efficacy of the pharmacological treatment? Well, I will show you that if the patient has a urinary angle higher than 220 nanograms per ml, the probability to be a responder to treatment is much lower, to such an extent that a urinary angle level higher than 220 was the strongest predictor of lack of response to the treatment. Let me go on, because, you know, HRS-AKI develop very frequently in patients with acute on chronic liver failure. Well, we all know that acute on chronic liver failure is characterized by a very high degree of systemic inflammation. The higher grade of ACLF, the higher degree of systemic inflammation. So probably the higher degree of parenchymal damage related to inflammation in the kidney. So it is not surprising to observe that for any baseline value of serum creatinine at which you will start the treatment of HRS-AKI in the setting of ACLF, there is a reduction of the rate of response moving from ACLF grade 1 towards ACLF grade 3. But the most important message in this slide is another one. For increasing value serum creatinine at which you will start the treatment, there is a dramatic progressive increase in the rate of no response, a dramatic progressive decrease in the rate of response. This is why you don't use anymore the old classification of HRS into type 1 and type 2, because according to the classification, you should wait that serum creatinine go beyond 2.5 milligram DL before to make the diagnosis and to start the treatment of HRS. Nowadays, we speak about HRS-AKI, and there is no more cutoff value of serum creatinine at which you will make the diagnosis of HRS-AKI and you can start the treatment of HRS-AKI. Let me go on with another small point. Some years ago, in two small clinical trials, both performed in India, it has been stated that in the treatment of HRS-AKI, noradrenaline was as effective as terlipressin in terms of recovery of renal function and in terms of 1 month survival. This is not true when the HRS-AKI develops in the setting of ACLF. In the setting of ACLF, terlipressin is much more effective than noradrenaline in the treatment of this complication, in terms of recovery of renal function and in terms of 1 month survival. Why? We don't know. But there is some evidence that in experimental model of decompensated cirrhosis, terlipressin can exert an anti-inflammatory action. Let me go to the final question, which is the evolution of the parenchymal damage in patients with AKI, and particularly in patients with HRS-AKI. Let me highlight this problem according to the response to the pharmacological treatment, moving from full responders, so moving from patients with transient HRS-AKI. We define the full response on the basis of the normalization of serum creatinine. But if we look and we measure the GFR, we can recognize that the recovery of renal function is only partial. Let me move now to the most important point, patients with persistent or progressive HRS-AKI. Well, let me say first that persistent or progressive AKI is more frequent in patients with an initial or peak AKI stage 2 or 3. Is more frequent in patients who develop AKI in the setting of acute on chronic liver failure. Is more frequent in patients with very high level of urinary NGAL. Said this, let me address the question. The evolution of persistent or progressive AKI on the histopathological ground is toward cholemic nephrosis and or acute tubular necrosis. On the ground of definition, the evolution of persistent or progressive AKI is towards acute kidney disease and chronic kidney disease. Let me highlight that acute kidney disease is associated with a deep negative impact on survival in patients with cirrhosis. The final point, the evolution of persistent and progressive AKI towards acute kidney disease and chronic kidney disease may imply the need of RRT or not. And it is interesting to observe that the need of RRT is associated to a very high serum level of quinolinic acid that I mentioned before. On a clinical ground, the decision to perform RRT in patients with cirrhosis with persistent or progressive AKI is a challenge, particularly in those who develop AKI in the setting of ACLF, because that you can see that if the number of organ failure is higher than 2, the mortality rate in patients who will receive RRT is very, very high. So let me summarize what I said. Patients with advanced liver disease frequently develop AKI. The diagnosis of AKI should be based on the KDIGO criteria. The nature of HRS-AKI is predominantly functional, but may be associated with some degree of parenchymal damage. The differential diagnosis in between ATN-AKI and HRS-AKI is complex, but may be facilitated by new biomarkers. There is no more cutoff of serum creatinine at which you can do the diagnosis of HRS-AKI and at which you can start the treatment. Terlipressin plus albumin is very effective in the treatment of HRS-AKI. And finally, patients with persistent or progressive AKI, in spite of the pharmacological treatment, may develop acute kidney disease or chronic kidney disease with or without the need of RRT. Thank you very much for your attention. I apologize because I cannot share the discussion, but I trust Diana, Rocky, and Florence, and they will be able to support my absence. Thank you very much again for your attention.
So, we would like to thank Professor Angeli, even though he's not here with us, for a wonderful talk. So we'd like to take the discussion forward. And Professor Diana, would you like to take forward the discussion?
Yes, thank you very much for this, for your eloquent lecture, Professor Wong. Let me throw off the first question. You discussed about the difference of microbiota. There are already studies now talking of transplantation of microbiota. Do you think it has its worth in patients with SBP? Do you think the difference of probiotics or maybe the use of them will be helpful as a preempt on patients with severe liver disease?
Yes, there are indeed publications on the use of fecal transplant to change the microbiota in these patients, but there is actually no study so far directly aimed at prevention of SBP. People have talked about the use of probiotics, prebiotics, but they really haven't shown much difference in terms of the preventing the development of SBP.
Okay, I also had a question to Professor Wong. Looking at the recent literature which is coming up on norfloxacin, which is actually not helpful as a primary prophylaxis or as a secondary prophylaxis, the data was also presented this year in ASLD that norfloxacin was causing more bacterial resistance. So, what do you suggest now?
I actually can't hear you. There is a lot of echo. It's not clear at all.
There is an echo, Rocky. Maybe you have two gadgets open.
Okay. Is it clear now?
Maybe
not much better.
One gadget.
But I don't have any other Zoom open on any app. Okay, I wanted to ask about the norfloxacin.
Yes.
Used as a primary or secondary prophylaxis. Looking at the recent literature, that it is rather detrimental. What do you suggest? Should we be using norfloxacin or should we not be using it?
I think your question is relating to the use of norfloxacin.
Yeah,
is that correct?
Yeah.
Norfloxacin is still the recommended antibiotic, although it is not available in some countries, such as the United States. However, if in a country where the local antibiotic resistance pattern says that there is a lot of norfloxacin resistance, then you will need to tailor the secondary prophylaxis accordingly.
Sure.
There are questions in the chat
box.
Yeah, let me just throw off one question in the chat box. What do you think of the case that was given by Professor Paulo recommended serial ammonia in spite of patient having encephalopathy, and in a patient in a resource-limited country, this seems to be requesting ammonia. We don't really request ammonia that often. Do you do this in clinical practice? I think this is coming from a young hepatologist.
I personally don't do it because when you take the blood for ammonia, you really need to put it on ice and you need to run it off to the lab. Otherwise, the levels will fall off. So usually I make the diagnosis of hepatic encephalopathy clinically and make a decision whether to give the patient lactulose or not, depending on clinical assessment, rather than using the ammonia, because my institution doesn't measure it. And I have to send it across the street to the children's hospital to measure it. And in the middle of winter, it is virtually impossible. So we don't do it.
Okay, so there's another question here about the use of prophylaxis, and I think this is the fellow that is going to see you in the future and to train under you, Professor Nico. Dr. Nico.
Yes.
His question is how long. Hello, can you hear me?
Yes.
He was
Yeah.
asking if hello, yes, okay, I think that's a little clearer. The use of SBP prophylaxis, there is a lot of talk on antibiotic stewardship, and I don't know whether this SBP prophylaxis, similar to the concept of patients being given prophylaxis for COPD patients. I think that's the same strategy that we are looking into. So do you use it often? I mean, how long do you give it? And do you pulse it like like the COPD patients, they give it on the first week of the month. Do you do the same thing in your clinic, Professor?
As I mentioned in my talk, the recurrence rate after the first episode of SBP is 70%. And because recurrence is associated with a negative impact on survival, so it's recommended that patients should receive universal secondary prophylaxis. However, the same cannot be said about primary prophylaxis. As I showed in my talk, that patients who receive primary prophylaxis actually do a whole lot worse. So we restrict primary prophylaxis to people who are at high risk of developing SBP, such as those with severe liver disease, patients who have GI bleed, then we will, or patients who's got a low acidic fluid protein count, then we will offer primary prophylaxis to those patients.
The question here is, this is something that we often see. If the serum albumin is normal, do you still give your intravenous albumin and hope that in patients who develop SBP, do you use it as a parameter and a gauge when to give your albumin? And when do you stop it? I mean, do you stop it after 3 days, Professor?
You know that the albumin in cirrhotic patient is quantitatively and functionally subnormal. So even if the serum albumin, say, is 30 grams per liter, it is not working as well as a normal individual who has 30 grams of albumin. And so, yes, I do give it. Now, I also presented the data from a New England Journal of Medicine paper from 23 years ago, when they recommended giving 1.5 grams per kilogram of body weight on day 1, and then 1 gram per kilogram body weight on day 3. However, up to now, no one has ever done a dose response study on the use of albumin in these situations. So you can either follow the New England Journal of Medicine paper, because that prevented the development of AKI in these patients. I personally, because sometimes the residents just don't remember to order it on day 1 and then skip it on day 2 and order it on day 3. So I just give it for the duration of the SBP treatment.
Another question, maybe I can throw the last question in case I get lost in the internet. There are already a lot recognized gaps or deficiencies of the accuracy of serum creatinine. And in fact, some studies have used creatinine clearance instead. Do you think that's a good option to replace serum creatinine in the future? I know you were trying to ask about was it Professor Angelo on serum creatinine and ascites together. So what do you think is the best parameter for your patients that you can diagnose this condition earlier?
You mean diagnosing AKI?
Yes, earlier.
Yes. Well, creatinine clearance is derived from creatinine. So if you believe that the creatinine is inaccurate, the creatinine clearance will also be inaccurate. If you were to use cystatin C, then that is a lot more accurate than using creatinine, but cystatin C is not universally measured. And for now, all the guidelines and all the definitions are still based on serum creatinine. So we have no choice but to continue using it. The improvement of having changing it from a fixed level of serum creatinine to just a change in serum creatinine, that's already an improvement in the diagnosis of AKI.
Rocky, why don't you throw the next question?
Okay.
We can.
So the next question is about, it is especially directed to you, Professor Wong. They want to know if you would like to modify the dose of cefotaxime in the presence of marginally raised creatinine.
You still have got a very bad echo.
Yes, we both had the. She was asking. The question was, do you alter the dose of antibiotics, specifically cefotaxime, in the presence of a marginally raised creatinine? In other words, do you dose
Adjust?
Yes, dose adjustment of your antibiotics based on the creatinine?
Usually not as a rule unless the antibiotic is renally excreted.
Okay. And how do you one question here that will say, what about antifungals? Do you often give antifungals even if you've not isolated? Maybe if a patient is getting worse despite your antibiotics, do you put an add-on antifungals? How often do you see this in your patient, Professor?
If the patient is getting worse, what I would need to check is to make sure that it is not a case of SBP, but rather it may well be a case of peritonitis related to something else, maybe a surgical cause or ruptured diverticulum. So you need to investigate further. And if you can't find anything else and the patient's not getting any better, yes, then I would add an antifungal.
Rocky, what about well, Professor
Role
Paolo?
of biomarkers for the
Yes, Rocky.
I was asking about role of biomarkers, Dr. Wong, if you have any experience on use of biomarkers for the diagnosis of fungal infections.
No, I haven't used biomarkers for the diagnosis of fungal infection, no.
And when do you recommend an emergency liver transplant in ACLF patient who's recovering from SBP?
Sorry, say that again. You do still have a bad echo.
Sorry. I'm saying in an ACLF patient who has SBP,
yes.
When do you recommend a liver transplant?
If the patient has got a high MEL score, usually they'll put the patient and the patient's on the liver transplant list. They'll be put on hold when there is infection. They need to wait until the patient to have at least 48 hours of antibiotics before putting the patient on the list for liver transplant.
Mhm.
Okay.
And
So my question was supposing if the please.
how about RRT?
Go ahead.
When do you recommend, or do you let the nephrologist do the recommendation of doing RRT in your patients?
No, I don't let the, I will consult a nephrologist, but as a rule, it's a consensus decision rather than letting the nephrologist call the shot. As a general rule, if the patient is a transplant candidate, we will start RRT as a bridging therapy. If the patient is not a transplant candidate, then giving RRT is futile. And so I will discuss with the family about palliative care if the patient's AKI is not responding to treatment.
Thank you. I think the last question I was interested in the lecture of Professor Paulo on quinolinic acid. Do you have an experience on it, Professor?
No, I haven't used that. No.
Yeah, this is the first time I've heard it, and
Yeah.
it's maybe in the next few conference we can have his opinion on it. Are there any other questions on the floor? I think there's none, and I think Professor Wong is tired already answering all our questions. So we'd like to thank, of course, Rocky. Why don't you give the closing?
Yeah. I would just like to say it was a wonderful session. Thank you, Professor Wong, for taking up all the pains of answering all the questions and for a wonderful talk and being with us. And I would like to thank all the our chairpersons, our panelists, Professor Baiko, moderator Professor Diana, Manoj sir, and Professor Lin for organizing this good case series and this good discussion on some hot topics that we and the challenging areas that we handle in managing these patients with cirrhosis. Thank you so much. A very good evening to you.
And thank you for asking me. I've had a wonderful time. Thank you very much.
Thank you very much,
Thank you, ma'am.
Diana, Wilson,
Thank you,
Wong.
sir.
Thank you. All right.
Thank you,
Good
ma'am.
night. Good night.
Bye.
Bye-bye.
See
See
you
you
sometime. Okay, bye-bye.
See you sometime.
Yeah.
Yes.
Yeah. See you.
Thank you, Rocky.
Thank you.